So you're talking about the AC joint dislocation.
So for my part of the presentation is the acromioclavicular. Yep. Next.
Yes.
So first we have to look at the anatomy first. You can see that the AC joint is composed with the AC ligament and the CC ligament. So basically, the AC ligament is like the intrinsic compartment, and there's like the superior, inferior, anterior, and posterior components. The superior acromioclavicular ligament is the strongest. And for the CC ligament, if you can see the picture, there is two components which compose of the conoid and the trapezoid. These are the extrinsic part. And for the dynamic stabilizer, it composes of anterior deltoid and trapezius. And it is a diatrodial joint, which makes up of fibrocartilaginous intra-articular disc. Next. So what is the most common pathophysiology? So we actually learned this in the bedside. The most common is direct injury, which is what Ajahn showed us when there's a bicycle injury, and then the patient falls on one side onto the tip of the shoulder. So there is a direct force to the acromion with the shoulder adducted, and the acromion will move downwards immediately, while the clavicle is stabilized by the AC joint ligaments. So this causes the AC joint dislocation, but also rarely indirect can occur as well. So it results from falling with an outstretched hand or arm with like an axial loading superior directed force. And it's typically only affect the AC ligament only, not the CC ligament. Next. So the clinical presentation that a patient will come to you is typically pain at the AC joint. And for physical examination, number one striking that you can see, especially for the patient we saw just today this morning, is abnormal contour and lateral clavicle AC joint tenderness. It can also have instability, both horizontal and vertical instability, depending on which ligament is intact or which ligament is damaged. The special test that we also did today was O'Brien test and cross-body adduction. For O'Brien, as you can see, like we have to do both the supination and pronation of the arm. If you supinate the arm, and it should get better, and if you pronate the arm, it should hurt during O'Brien test. Okay, so next. So as you can see here, the first picture, there's vertical translation, and that's mainly with the CC ligament. And for the horizontal instability, it's from the AC ligament. Next. And this is the video of like a recurrent AC joint displacement.
So deformity will be obvious when you're performing the adduction, right? Or
Yes.
you're performing the scapular protraction, okay? The chronic AC dislocation.
So what imaging should we send in for patients with AC joint injury? The required wheels are bilateral AP of the AC joints, and also the Sanka wheel and axillary lateral wheel. There are also some wheels that you may have seen before. For example, the weight is stress, but it's not commonly used. I will tell you the detail in the next slide. So the Sanka wheel is basically an underpenetrated wheel with like a cephalic tilt. And for the axillary wheel is when you have the patient abduct the shoulder of 90 degrees, and then you have the X-ray beam assessed by horizontal displacement. Next, for stretch radiographs that I mentioned earlier is basically when you hook a weight to make sure that it's hanged with weight. So these stretch wheels are quite painful and don't really provide new info, so they aren't routinely used anymore. I think with physical examination and typical X-rays, it's quite obvious to diagnose without having to do this stretch radiograph. But as you can see here, with weight, it is a lot more obvious. Just like when you adapt your shoulder, it's quite obvious at the deformity. So onwards to Rockwood classification of the acromioclavicular joint injury. So there are 1, 2, 3, 4, 5, 6 types, and the types matter because the treatment is different, and you have to decide what some of the type. For example, not type 1 and type 2 is usually done with conservative treatment. For type 3 is still controversial. Some doctor will choose to do surgery, some won't. But for 4, 5, and 6, it is an indication of surgery. So I will explain to you the differences in the type in the next slide. So in type 1, you can see that there is only a stretch of the AC ligament without any rupture. In type 2, there will be the partial rupture of the AC ligament. And then type 3, there will be complete rupture of both the AC and CC ligaments. And for type 4, there's a clavicle displaced posteriorly over the acromion. And type 5, the clavicle will displace up just under the skin. And then for the type 6, it's quite rare. Basically, the clavicle will displace to be underneath the coracoid. So as I have told you, the treatment conservative treatment is indicated when, for example, there is a Rockwood type 1 or 2, or if it's not yet be chronic. So basically, the cutoff point is within 3 weeks. If it is chronic or more than 3 weeks, then conservative treatment is not recommended. So the conservative treatment can include beef-spring immobilization with rest or ice and physical therapy. For
just sling, just the sling.
So the first phases is.
Do you need to try to reduce it in England? Do you need to try to reduce it like the shoulder dislocation, hip dislocation? You need to try to reduce it, right? So in what type 1, 2, 3, if you try to conservative, what do you think? Do you need to reduce it or not? And if you need to do that, how to do that? You understand my questions?
So your question is whether we have to reduce it, right?
Yes, because it's a joint dislocation. Is the reduction needed?
I'm not
sure.
quite sure.
Okay, who can answer that? Many แพรวาอิงฟ้า win.
I was looking at the last slide.
I know
and then,
I don't know how it's reduced. I don't know what way.
Yeah, I think
You see
for
that
the
in the
lower
treatment, it just sling, you see? Just sling. That means you don't need to reduce it. You need to accept the deformity. We call this skillful neglected. Skillful neglected. การละเลยอย่างมีชั้นเชิง Okay? Understand? That is the treatment. Skillful neglected. But you need to discuss with the patients that can you accept the deformity? If the patient is very big size, like Saga, right? He's fat, so you cannot even see his AC dislocation. But if you're very skinny, like cat, you can see the deformity of the distal clavicle. Okay?
Thank you, sir.
So it's not the truth. Okay? So discuss with the patients if you want to try the conservative treatment. Okay? But for AC joint type 2, in the future, if you have active, the patient may have arthritic change. Okay, you should discuss with the patient like that. But you don't need to do surgery because it's too much. Okay?
Thank you, Paajan. Okay, for that the conservative treatment, the surgical management can include the open reduction, internal fixation, or the ligament reconstruction. So you can either do the fixation at the AC joint or the between the coracoid and clavicle, or you can also reconstruct the ligament. So the indication includes type 3 by consideration, or in type 4, 5, and 6. Or if there's a failed conservative treatment, or if there's more than 3-week chronic AC joint injury. Yeah. There are like a lot of ways in which you can do surgery, but as you can as if you remember in the bedside teaching that we discussed earlier, some of the fixation ways are not preferred. For example, pin fixation, because of the pin migration, maybe to the heart, the lungs, the great vessels that are quite dangerous. So it's not used as often as it before in the past. There can also be use of hook plates or other techniques, such as like an open arthroscopic technique of ligament reconstruction, or maybe like
clavicle resections.
The intramedullary AC recon.
Yeah. So actually, you don't need to know the details of the surgery. Okay. So if the patient come before 3 weeks, we do the AC joint fixation. Okay. No need to do reconstruction. But if the patient come delayed, there will be scar tissue. So it's useless to do the fixation because the scar tissue cannot be healed. Okay. Okay, CJ Cat, can you show one examples of the AC joint? This is chronic, right?
Okay.
Oh yeah, this is the.
Right, sir.
Just make it short.
Yes, sir.
So nowadays we use the arthroscopic assisted. So you put the scope into the joint, okay, and then we can performing the fixations.
Yes,
We
sir.
go into the joint to identify the coracoid process because the coracoid is the most difficult structures if you approach it from the open surgery. Okay,
Yes, sir.
so that's a coracoid process. Okay.
So initially, we use the scope to reach the coracoid, sir. We basically clean. Sorry. So after that, sir, once that is done, we go out and then make an incision over the distal part of the clavicle. And then so there we dissect. Usually with surgical types of AC joint injury, the deltotrapezial fascia is already torn. So we will repair this later. But basically, what we do is, since we already cleared the coracoid process from underneath using the scope, we pass, and then of course we clear it from above. So once we identify it grossly, we pass a suture like that, and then we shuttle if it's a fixation, then we shuttle the sutures to fix, and then if it's what do you call this? If it's reconstruction, we shuttle the graft. So if you can imagine, the coracoid is like a hook. So the sutures or the graft is hooked on the coracoid. Then after that, we make 2 holes just over
stop here.
Yes,
you understand? The student, you understand, right? You pat the suture around the coracoid, right? And then you tie it back. It's like you're doing the CC fixation, right?
Yes.
But you don't need to try to repair the CC. You just reduce it in press, so the ligament can heal by itself. Okay, because it's impossible to repair the CC, because when it's torn, it's like very bad tissues. So just repair it back, reduce the clavicle, so the CC ligament can be healed. Okay, if you do that before 3 weeks. Okay.
Yes.
Okay, next. So go quick.
So after that, we make 2 holes over the clavicle, and then shuttle again our sutures there, just like in this illustration. So, and then after that, for fixation, we put an endo button there.
Okay. You put the button on the top.
Yes, sir. Something like this, sir. We put a button on the top, and then the sutures we tie to the button. And then the limbs, after tying, the suture limbs, we place it under the acromion. I'm not sure if there's an illustration for that.
Yeah, that's one.
But basically, from here, from the distal clavicle, we pass it underneath the acromion to mimic the AC ligament and reduce the AC joint, and then fix it also with the K wires.
So this is a fresh reconstruction, right? Repair.
Yes, sir. This is repair, sir.
Fresh repair.
Oh, this one, sir.
Then we pat the suture. Yeah. Yes. But now I think I show you the new techniques, right? I did not perform the tunnel, the hole in the acromion. Okay.
We go underneath the acromion, sir.
Yeah, go underneath. Yeah.
Yes, sir. That's it, sir. And then after that, do not forget, we always repair the deltotrapezial fascia.
Okay.
That's it, sir.
That's it, and then repair it back, right? Extern, you understand, right? So we need to stabilize both the CC and also the AC. CC ligament, AC ligament. Okay.